So sorry, folks. Can y'all hear me? Awesome. I apologize for being late. That was for two reasons. One, I ran over a little bit longer with my child and adolescent class, and then was waiting there for like 2 or 3 minutes because I clicked on my Zoom calendar. I've got all of the classes up, and I clicked on Sunday, November 6th class, and I started that class. I was like, well, where's everybody? Like, I thought everybody just decided not to show tonight. I'm gonna have to just talk to myself about this, which honestly I've done before. So I could talk to a brick wall about this stuff. It's just a lot better when you're talking to people. How's everybody tonight? Some of y'all were in my other class. Susan, you were in my other class too, right?
Yes.
Yeah. Somebody sent me a chat earlier,
It
and
was,
I don't.
It was me. It was me.
It was?
Yes, I think I have your wrong email address because I want to talk to you about a personal question about a PANDAS referral.
Sure.
And so because it seems like you know about that and not many doctors do. So I just was wanting to get your email address if I could to send a message there because I got a bounce back from the Amberton one.
You got a bounce back from it?
Yeah, and it could really be, it could have been on my end. I should go back and see what happened, but
I'm so sorry. That
no, I mean, and then I sent a message in Moodle, but sometimes that isn't a great tool,
it's Moodle's a challenge at times because
yes.
like I'll get a message on my phone, like an alert, and I'll try to get in there, and it takes like 5 minutes to log in, and then for the Moodle to like pull up the reply button, and then for me to click on the message, and then for it to reload it's just ridiculous. Dana, you can't hear me, is that right? Can you hear us now?
I think it was her that didn't understand. I couldn't hear the other time too, but then it came back up.
How about now? Like that, you remember that commercial? Yeah.
Dr. Armstrong, I sent it to Levi.Armstrong. Am I wrong? Do I have that wrong?
Here, I will.
My Amberton, yeah, my.amberton.edu. It bounced back. It said address not found.
Yeah, so it's larmstrong@amberton.edu.
Okay,
there you go.
That's fine. Thank you. I'll resend there.
Absolutely. And you can't hear us at all? I guess not. So hang on one second, guys. I don't think she can hear us. Can't. Is that right? Okay. Yeah, so you can email me there, and then, I'm not worried about you guys like abusing this at all. You're also always welcome. This is for professionals and non-patients only. Okay. It's important. You can also text.
Thank you.
Yep. Because that's often a little bit quicker for me to get to.
Okay.
I'm less likely also to avoid it.
I have that.
Sometimes I avoid emails.
I understand. You gave us that number at the beginning of the class, so I'll find it.
Yeah.
I have it right here. Is it on the syllabus?
That number?
No,
it's in the text. Oh, hang on. I didn't put it in there.
Did you put it in the chat? Oh, okay.
Yeah, I'm about to put it in the chat. Well, that's not how I do it. There you go. There we go. So feel free to text, and yeah, just remember that that's only for class related questions, clinical questions, that kind of stuff. Or if I can help in any way, just that's not how if you were to refer somebody
Of course, yeah, of
to
course, I
me,
would-
right?
yeah.
Like you need to go through the practice for that. So back
What if
when
we
I
just
started
wanna
my
chat?
practice, right? Yeah, with all my free time. Yeah. My own mom has a hard time getting me to reply to text messages sometimes, so good luck with that.
Sounds like my
Well, and it's just that like I can on any given day I get probably 20 something text messages, like because that's how my front office like just the most efficiently can communicate with me. And with my resident being a few doors down, like in down the hallway, instead of us having to get up and down, we just tend to do that. And so we end up just getting a bunch of messages. And by the end of the day, I'm kind of messaged out. But with all that said, what I would say is that for those who weren't in the class, well, my child and adolescent class, the game plan for tonight is to kind of walk through the anxiety disorders and stress response in preparation for talking about trauma. That's really what I should have said last class, but I do want to highlight what occurs in the brain between anxiety and OCD, stress, and all of that, because it's all overlapped and you really can't understand why the symptoms are occurring unless you understand what's going on in the brain. And hopefully tonight will give you that baseline. Let me share the screen here. Pull up.
I don't know if you
PowerPoint
shared with
slides.
this class already why your video is not on. They might be.
Oh, I'm sorry. Yeah. Also, my video isn't on because I left my webcam at my office, my work office. I brought everything home and somehow forgot the webcam, and so you just get my voice tonight. But hopefully that doesn't matter much related to your learning, because we're just going to look at slides anyway. So, but if you need to see me, I'm sorry about that tonight. You're just going to be able to hear me. We are officially in week 6, and like I told the class from last week, I think on your calendar there, we've got a week break planned for next week, or for this coming Sunday. But there's probably a good chance that we're going to still have that I might have another class this coming Sunday. And again, these are all just optional anyway, so not like you're going to get in trouble if you don't go to it, but I might offer another one for this coming Sunday just because I think it's going to be helpful. And then with that said, let me get my screen shared. All right. Can everybody see that? PowerPoint? Perfect. All right. First and foremost, we need to be able to understand what is going on in the brain when we are anxious. But before we can do that, we have to define what's the difference between stress and anxiety, particularly as it relates to an adult being aware of being anxious. So can anybody tell me when you're aware of an emotion, what part of the brain allows you to be aware of an emotion? Is it your backal lobe or your frontal lobe? By the way, the backal lobe's not, I'm just making that up. I used that as a test question one time, by the way. It was like, what part of the brain allows you to have self-insight? The backal lobe, the sidal lobes, the inside lobe, or the frontal lobe?
Guessing it's the frontal lobe.
Absolutely, frontal lobe, not the backal lobe, because no back lobe. Frontal lobe. And as an adult, if all things went neurodevelopmentally normal, that means that our frontal lobe, and as long as we haven't had any injuries or any illnesses or diseases that are causing the brain to decline physiologically, the frontal lobe, one of its jobs is to be aware, self-aware. And the ability to recognize that you are feeling an emotion. And I'll use this example. Does anybody ever get hangry? Like you're just like real grumpy, then all of a sudden you eat something and you're like, oh, I was just hangry. Really, wasn't really mad. It's just that I was hungry. Being hangry is usually the result of not being aware of one's own emotions or where the emotion is coming from, right? But it is our frontal lobe that allows us to consciously perceive that we are feeling anxious or sad or happy or so forth. Now, obviously, compared to kids, adults have a verbal capacity that's much greater, so that in most cases, you know, as long as our intellect is sufficient, adults can identify with words what they're feeling. We have a way to take this abstract feeling, say, yeah, I am feeling nervous, or I'm feeling sad, or I'm feeling joyful. Now, what's pretty cool about that, by the way, this is kind of a side note, you actually stop feeling that emotion as powerfully when you, even just in your mind, you don't have to say it out loud, just in your mind, name the emotion. Does anybody know what part of the brain deals with expressive language abilities? That's okay if you don't, because you really don't need to remember it. But let me see if I can show you a picture of the brain and part of the brain that deals with expressive language. So I'm going to pull up this real quick. The just 1 second here. Sharing the screen. And there you go. Can y'all see that?
Mm-hmm.
So we are looking at the front part of the brain here.
Mm-hmm.
This is the frontal lobe.
Mm-hmm.
Back there's the backal lobe. Just kidding. That's the occipital lobe. This is the parietal lobe. This is the temporal lobe, brainstem. Your eyes are like right here, by the way. This part of the brain right there is called Broca's area. B-R-O-C-A. And I'll give you an example. People who have stroke and who cannot translate their thoughts into words anymore, or they struggle with articulating their words. They have like slurred words, what's called dysarthria. That's because they've had a stroke to their middle cerebral artery system and the anterior portion of that leads to the Broca's area. That's not an uncommon stroke area, by the way. That happens pretty frequently. Anyway, what you need to know is that this is on the outside of the brain. This is the Broca's area, but if we can look on the inside of the brain here, where these connections also go, they go inside the brain, and guess what they connect directly to? They connect directly to the amygdala. You know, remember what the amygdala is? Amygdala is the fight or flight center. It's the fear response, or the emotional fear processing center of the brain.
The smoke detector.
Yes, I like that.
Yeah.
I like that. That's a great metaphor. I don't think I've ever said that before.
It helps me remember it.
Yep, it's the smoke detector. It's if you've ever seen Inside Out, it's the character of fear. It's the part of the brain's like always aware and vigilant to your surroundings and what's going on, which is why it's so intricately connected to the hippocampus, because the hippocampus is where your brain says, this is important memory, this is not. This is an important memory, and this is not. And it determines the level of importance of any memory or any information that your brain's trying to remember based on how much the amygdala says this is related to your survival, which is pretty cool. It's a good thing we don't have to like consciously do that, right? We would be exhausted. I mean, I'm exhausted anyway. Can you imagine? So going back to Broca's area and how that relates to the naming of emotions is your ability to say, I'm feeling anxious right now, literally activates this part of the brain. Even if you just say it internally without saying it out loud, it activates that part of the brain, which in turn inhibits the amygdala. It automatically calms the amygdala down because this part of the brain cannot activate simultaneous with the amygdala. And it actually makes sense from a symptom standpoint, because when people, the more anxious you get, the less ability you have to even talk. So you talk about stress, like when people are traumatized, a lot of times, like when in the middle of like trauma, they can't verbalize anything. And that's because the amygdala is overriding the Broca area ability to translate thoughts into words. Is that making sense so far?
Okay, can you repeat the last part? You said the amygdala is overriding.
Yep, the amygdala is overriding the Broca's area of the cortex right there. Whenever our stress is so much, or our anxiety is so much that we can't talk anymore. And there's a childhood disorder that occurs more frequently than you would believe, called selective mutism, that happens for the same reason, by the way. If you've ever seen a kiddo that has selective mutism, they won't talk around like anybody except for their parents. You'll talk to them and you know that they can talk, they just won't talk. And it's not really intentional on their part. It's really because the anxiety is so great that they can't talk. This is also why, by the way, if you ever get nervous, or if you remember getting nervous, like when you had a crush on somebody, You're trying to talk to them and you're just fumbling over your words, super self-conscious. You're just like, well, blah, blah, you can't, it's not coming out clearly. That's what's happening neurobiologically. Let's go back to PowerPoint here. All right. So the purpose of me telling you that is because in addition to that verbal ability, we also have an unconscious drive or subconscious drive that fine tunes how much anxiety we experience. And I'm going to pause this real quick because I don't think I finished my thought earlier, and I apologize. Stress is the physiological response of the body. Anxiety is the subjective experience of stress. In other words, anxiety is a cognitive and psychological phenomenon. Stress is a biological and physiological phenomenon or process. Now, we identified in our child and adolescent class earlier that you don't have to be psychologically aware of your anxiety to feel anxious, because kids certainly feel anxious at times, even though they're not necessarily aware that it's anxiety that they're feeling. But with adults, we've got a frontal lobe that's fully developed. And that means that that stress response is going to be much more likely to be perceived subjectively by that person as anxiety. The problem is the difference between kiddos and adults, and this is an important distinction here, is that adults, what comes with maturity, in other words, what comes with the frontal lobe maturing is the ability to anticipate the future with greater breadth. And I don't know if you've ever had to babysit or if you've ever had kids, around age 5. But generally, kids around age 5, they don't really think about the long-term implications of things, right? So in other words, they don't really, there's times that you kind of wish they had more anxiety because it might help prevent them from impulsively doing stuff. As compared to an adult where, we have the ability to cognitively think about, what am I going to do when I'm 80? How am I going to pay for health insurance? Or, gosh, I really need this quarter to go well so I can keep my job. Right? Those are adult level cognitive concepts that, because we have that ability, we have, compared to kids, a greater capacity to generate our own stress response. And if you watched any of the stuff I put there on why zebras don't get ulcers from Robert Sapolsky, by the way, you should read that book in all your free time. It's the best book out there as far as I'm concerned, as it relates to this stuff, because Sapolsky's a really great writer. He's funny, accessible for everybody. You don't have to be an endocrinologist to know it. But his main point in his research has shown basically that what separates humans from just all the other animals is that we have the ability to intrinsically initiate the stress response, which then works like a positive feedback loop. Because I would like to see a show of hands who has the ability, I think I even asked this last class, who has the ability in here to control the future like 100% of the time? Anybody? I hope somebody raises their hand sometime, because I really want to know that secret, and I would like to inform them they are about to be a billionaire. Because the truth is, we can foresee the future cognitively really well, but we don't have the capacity to time travel to actually make it happen. We can't control for everything. Because there's some uncertainty there, our amygdala isn't convinced that what we're saving right now for retirement is enough. And so the amygdala says, yeah. I hear you, frontal lobe. I mean, that's cool that you got this account going, but have you considered, what are we going to do if a meteor hits the planet? That's what's occurring in our brain at all times. And that's the normal process for the most part, because in order for us to live as long as we do as humans, our amygdala needs to be very active and very vigilant in anticipating the future, and then telling the frontal lobe, hey, you need to be aware of the stress so that you can anticipate and think about all the things that might interfere with your survival. And that's good. And I would call that the healthy degree of health, like existential kind of anxiety. That's why, as an existentialist, by the way, that's my underlying personal counseling philosophy, I don't believe all anxiety is a diagnosable anything. I think it's a lot normal. And biology would back that up. Otherwise, we wouldn't have an amygdala. The second part that I want you to remember here is that we've got a nervous system that is separated into the out of the autonomic nervous system. We have two branches of that. We have the sympathetic and the parasympathetic drive. In other words, there's one whole system, like half of all the cells in the brain and your spinal cord and your peripheral nervous system, half of all those are trying to be in fight or flight mode. And then the other half are always trying to be in rest and digest. They also do other stuff. So like some of them, think about math, but half of those are sympathetic and they are trying to get you in fight or flight. And half of those, the other half, are in the rest and digest. That's the parasympathetic side. And there's a tug of war occurring on a daily basis with all that. And that is the tug of war that's occurring, that's normal in all anxiety disorders, in OCD, in trauma disorders, and probably mood disorders. That tug of war is being won predominantly by the sympathetic system as compared to the parasympathetic system. Well, the question is why? What's making the sympathetic system stronger than the parasympathetic system? Well, from a neurochemical standpoint, guess what? When you think a anxiety or when you think an anxious thought, your amygdala says, whoa, this is related to survival. It then in turn quickly tells your hypothalamus, or the the HPA axis, the hypothalamic adrenal axis, HPA, that stands for. It tells that system, hey, we need to get ready for fight or flight. And what does adrenaline do?
Jumps you up.
Yep. It doesn't make you sleepy. It's the opposite. In fact, adrenaline, you want to know the word for that is, by the way? Norepinephrine. Adrenaline, noradrenaline, and norepinephrine are molecularly about essentially the same thing. So that anxious thought turns on your stress response, which then overpowers your parasympathetic system, causes the sympathetic system to win that tug of war. And as Sapolsky points out, and this is an important point, that's really helpful if we were being chased by like a lion, right? So like you need that system to turn on quickly and say, okay, it's time to stop thinking about, my retirement and just start thinking about me running fast. And I need to get the blood pumping to all my muscles. I need my pupils to dilate so I can see as much as possible. I need my heart rate to increase. I need my breathing rate to increase. I need my blood pressure to increase. I also need to stop worrying about procreating. So my sex drive needs to quit. I need to stop digesting food and producing insulin. It is that fight or flight response that's supposed to turn on. And then once we, outsmart or outrun the lion, hopefully, we're no longer in that threat. And our brain is supposed to then say, all right, we're good now. Everybody turn the lights out. Let's go back to parasympathetic drive. And it does that, or supposed to do that fairly quickly. But the problem is that as humans, we have the ability to say, well, but I'm out of that situation, but it could happen again. And then we start worrying about it. And I don't know about you guys, but I've never really had a worry that I've never intentionally worried about something. Has anybody ever just intentionally worried about something? It's like woke up having a good day and was just like, you know what? I'm gonna start worrying about, I want to start worrying about my job. I want to start worrying about, retirement. Like, no, it's not a intentional process. Nobody has the thought of like, I'm gonna make myself worry about something. Every worry that occurs, and this is the point I made in last class, is therefore an intrusive thought. And as you might recall, if you were in my last class, intrusive thoughts, you need to associate with obsessive compulsive disorder. And then it might seem like I'm kind of hopping around very quickly, but I want you to know I'll come back to it, I promise. But OCD, all OCD is obsessions, which is another word for intrusive thoughts, which produce anxiety and the stress response for that matter. And then we are conditioned to compulsively do some sort of behavior to make in an attempt to control the intrusive thoughts, in an attempt to stop those intrusive thoughts. So in other words, I have an intrusive thought of, did I lock my door? I can't remember if I locked my door or not. Did I lock it? I thought I did. You know what? I'm just gonna go check to make sure I locked it. So in that case, that I lock my doors, the intrusive thought causes anxiety enough for me to compulsively, in order to finally gain control over that intrusive thought, I go check that lock. which for a short time turns down the stress response. That's the way it's supposed to go. But what happens in OCD and generalized anxiety, social anxiety, and trauma, for that matter, is that we have this intrusive thought followed by some sort of compulsive behavior to control that thought. But it is the basal ganglia, which is like right here, and its connections with the amygdala and the prefrontal frontal lobe, but it's the basal ganglia breaking down in its ability to start and stop our thoughts, feelings, and behaviors. I'll say that again. So with all the anxiety disorders, including OCD and including all the trauma-related disorders, the reason why those are disorders is because there's a problem happening biologically between the connections of the basal ganglia, the amygdala, and the prefrontal lobe. Because the basal ganglia's job is to tell the amygdala, now it's time to feel this, now it's time to stop feeling this. It's also its job to tell the frontal lobe, now it's time to start worrying about this, now it's time not to worry about that. Or not even that, it's tell the frontal lobe, now it's time to think about this or be aware of this, and now it's time not to be aware of this. In addition to that, by the way, you might know the basal ganglia better in relation to what I said last class, Parkinson's disease. It causes tremors. So all a tremor is, by the way, is the brain not being able to control motor coordination to the extent that it causes an alternating frequency of motor movements that is really just the body trying to pinpoint like balance. So if you hold your hand out and everybody has just like a little tiny tremor, if you had too much coffee or maybe you're anxious, you're going to have just a really high frequency tremor, low amplitude. But your ability to hold it out there without it shaking back and forth substantially is based on a whole lot of finely controlled and barely perceptible up and down movements and side to side movements of muscle tone and coordination, which is primarily directed by the basal ganglia, by the way. Now, I want you to think about that as it applies to generalized anxiety disorder or OCD, where the basal ganglia's job is to prevent the tremor, so to speak, of our own thoughts. It's there to give us conscious control, not just over our motor coordination and muscle tone so that we don't have a tremor when we hold our hand out, but also over the coordination and muscle tone of our own cognitive thoughts. So that when we think about retirement, it doesn't automatically lead to us also associating that with, you know, how that might affect relationships. And then, oh gosh, that reminds me, I'm worried about, you know, my aunt, if she's still upset with me or not. But I wonder, how are they doing financially? Because I know, see how that discontrol happens with generalized anxiety, because we've got an OCD that's not preventing the tremor of thought. And I'm here to tell you, when you cannot control your thoughts just subjectively, I promise you, the less control over your own thoughts you have, the more anxiety you're going to feel subjectively. more anxiety you are feeling subjectively is in direct correlation with what's happening in the stress response physiologically in your body. Does that make sense? In other words, the more you are aware of your own anxiety, biologically, that's correlated or directly proportional to also how much physiological stress response you're having.
That's a little scary.
I mean, it is, but it also, here's the thing. The positive side of that awareness, by the way, of knowing that now, is that we can tackle anxiety from two different directions. We can tackle it from a physiological side and from a psychological side. We can gain better control over it, in other words.
Yeah, that makes sense.
For example, deep breathing doesn't just slow down the physiological stress response. And it does that, by the way. It does. You can't deep breathe like for 20 minutes and have the same like racing heart rate that will be associated with a panic attack. It's impossible. It's physiologically impossible to deep breathe and have a panic attack at the same time. Now, what that does indirectly then is that also decreases the psychological anxiety side by giving your frontal lobe more control over the amygdala, giving the basal ganglia more control over the amygdala too. So we can tackle it from that end. And then this is why cognitive behavioral therapy was even created for the most part, by the way, is that we can tackle it cognitively. Because, one, we know that just by talking out loud or in our head, that Broca's area is going to directly inhibit the activity of the amygdala. But also, specific skills and techniques on the cognitive therapy side give us the ability to control the thoughts better, to compensate for the basal ganglia's inability to fine tune our thoughts so that we can consciously fine tune those, whereas the basal ganglia was supposed to do it subconsciously. And then guess what? If we combine both of those together, that's how we get cognitive behavioral therapy. And I'm not telling you that's the only approach that you should ever take with anxiety or OCD or that kind of stuff. But I'm telling you, no matter what you do, if it ends up being effective in the treatment of anxiety, it's because you have incorporated treatment at one or both sides of that equation. Now, I know I haven't gone into the diagnostic criteria of the DSM-5 on all these anxiety disorders. I'm going to let you read through all that stuff yourself, but the easier way to conceptualize all of that is by understanding that we've got the same underlying drive behind all of these diagnoses. And even though the DSM separates OCD and even eating disorders and even like compulsive disorders from addictions and even addictions from trauma and all that stuff, even though those are all separate categories, you need to understand it is the same underlying pathophysiology that's occurring for all of it in relation to anxiety and the stress response. The difference is primarily in how the anxiety is manifesting in this person. In some, it might be compulsive, like, what it looks like OCD, obsessing about germs, and then compulsively, washing hands repetitively. Or in others, it might be the hyper focusing on social situations and showing up as social anxiety. But both are the direct result of there being a dysregulation of the networks between the basal ganglia, amygdala, and the prefrontal cortex. Okay. And I'm going to pause this there for tonight for this class, because that really kind of sets the stage for us to talk more next time about PTSD and trauma. In addition to, I'm going to go into a little bit more depth about OCD as well, but because that you really need to know OCD and also to know trauma, because trauma is kind of the same process, but just a little bit different because it has a different, an additional pathway that we're going to kind of talk about as well. But what questions do y'all have for me tonight? It's hard to hear everybody talking over each other, by the way.
I've got a question, and having mother that has progressive palsy, I noticed right when she was diagnosed that she had developed OCD. Is that like a precursor, or
So,
something she's had and just covered up until she couldn't cover it up anymore? Or
right, and I can't speak for her specifically, but I'll say, just because she's not a patient that I've never evaluated, it's just unethical
Right.
for me to do so.
Yeah.
But in general, all of those disorders that affect the basal ganglia, guess what? They often cause OCD.
Okay.
Because it's the same part of the brain that we're talking about.
Right.
Like Parkinson's, PCP, my brain's going blank, but there's, good grief. We've got Lewy body dementia included in there. We've got CBD. What's the not CBD oil?
I was gonna say that's pot.
Right. Gosh, my brain is going blank, but there's a whole list of them. There's
Okay.
multiple system atrophy, PSP. Gosh, can't remember the other one, but anyway, those all affect like
The
very tiny, like overlapping, but just a little bit different pathways within the basal ganglia, which results in almost all of those producing neuropsychiatric symptoms of OCD.
Okay.
And that's what's strange about psychiatry, by the way, is that in those cases, everybody on the planet that works with the patient will know that, okay, this OCD is neuropsychiatric because it's related to the dementia process that's happening.
Right.
But then it's like they forget that when they talk about just regular old OCD that happens, as if that's a different part of the brain. It's not. It's still a neuropsychiatric reason. And in fact, by the way, guess what? Most people are starting to lean, including myself, that OCD is actually it's primarily a neurological problem more so than it is a psychological thing at all, because it's coming up more and more that it's probably an autoimmune reaction to something.
Really? That's interesting.
Same reason why a lot of people with multiple sclerosis will develop OCD, by the way. Other questions? Cortical basal degeneration. That's what it is. It is CBD. I just couldn't remember what it's. Yeah. I looked it up, by the way.
Mhm.
That was a test question on my board exam, by the way.
Oh,
Yep. Well, if no more questions, then we will call it a night for tonight, but this was recorded. I will get it posted to Moodle. And then I will let you know in the next couple of days at the most, I'll send out a class-wide email with the invite if I can ensure that next Sunday will work to do another class. Okay. All right. Well, I hope
Thank
you'll
you.
have a absolutely. Hope you'll have a wonderful rest of your evening, and yeah, keep on keeping on.
Thanks, Dr. A.
All right. Y'all take
Thanks.
care.
Thanks.
Bye.
bye.